Bearded Biomed.
Ladies and gentlemen, welcome back to an all-new episode of the Bearded Biomed. I am joined here today with two gentlemen that we're about to get into a topic that not a lot of people talk about, but we're going to talk about it today, and it's beds and stretchers. The two gentlemen joining me today, hopefully you should know them well. They're very much trendsetters within the field, but to get into the conversation, I'd like to welcome Webb and Ryan, who know what they're talking about when it comes to this conversation. So, Webb, if you wouldn't mind giving yourself a little background, and Ryan, you can take off after.
Thanks, Chase. My name is Webb Clark. I have been in the HTM industry for 8 years. I work for a company called Emeritus Clinical Solutions that's based in Dallas. We're an HTM company that solely specializes in patient beds and stretchers. Our company's been around since 2012. It's a veteran-owned company. We cut our teeth working with the government, working with the VA Health Network, providing a white glove service wherein we provide full service for patient beds and stretchers with technicians who are always on site in firm fixed pricing. And in recent years, we've turned over that white glove service to the commercial market. I'm also the president of the Healthcare Technology Management Association of North Texas, which very proud to say both of y'all are a part of. We did some big things in 2024, and we've got a lot of traction here in the Lone Star State, working on all kinds of stuff from, doing an even bigger year this year and putting on our first annual symposium in 2026.
Well, I'm the Director of Healthcare Technology Management at Texoma Medical Center. I'm also just recently started as an adjunct professor at Collin College, helping out with the biomedical associate degree plan they've got there. I'm brought in to teach the imaging portion of that course content. And the HTM department I manage is an in-house department, and we work on just about everything from nurse call and beds up to the imaging equipment. So excited to talk to you guys about that today.
And I like that Webb brought up the idea to me. It was months back. I was at one of our North Texas get-togethers, and he was like, hey, why don't we talk about beds? Nobody talks about beds. And I was like, you're right. I don't remember the last time anybody's had a conversation about it. It's not even, no one talks about this stuff even at conferences either. Which
is crazy, Chase, because
it's like it's like a stigma almost for biomeds. There's a conversation to be had of, is a hospital bed, is a stretcher a medical device? And I would argue, yes, it is. It is the number one piece of equipment that a patient is always in, touching, being used.
When you talk about patients, they're concerned with a couple things. Because again, your patients don't know how to PM a infusion pump, and they're none the wiser if the sterilizers in your basement aren't humming, but they do understand comfortable sleep. They want to know, is the TV working? Is the food good? Was the staff nice? And how did I sleep? They do understand if nursing staff had to move them into a different room in the middle of the night. So when we talk about, patient satisfaction and the reputation of our hospital, you got to consider that all patient care, inpatient care, revolves around the patient being in the bed. I think ECRI has highlighted this, saying it's the most ubiquitous device in all of healthcare. So it's important. There's CMS reimbursements. Those implications are tied directly to the experience of the patient in the bed. All this to say that, I totally agree with you, Chase. Beds and stretchers, as far as HTM is concerned, they do not get the love or respect that they deserve.
That's true. Chase, you asked why don't we talk? I feel like there's a stigma, like you said. Some biomeds feel like they're above them. I got a sense of that when I worked when I first came into the field. Nobody wanted to touch beds, but when I went through an in-house conversion at this hospital, so I was a contracted biomed, and then I was tasked to turn it into in-house. And one of the first things we were faced with was beds. So, if any biomed out there, you kind of just ask yourself honestly, you think about what a bed is and what all the technology that's in them today. Who is best to maintain or manage that service, right, in the hospital? If you ask yourself that question honestly, I feel like there's no way you could answer, well, that should be some other department. That should be this department over here. Not to cast shade on anyone else in the organization, but we all know kind of where that belongs. And so whether or not we want it, if you think about the patient, and like Webb said, you don't have to be doing this very long to understand that these beds, they can make or break a patient's experience within your facility. So it's very important that they're maintained properly. And that's why I chose to take it on. Another big thing for me, not only can you justify having a more staff to work with beds, but it protects your staff. It protects your program. The last couple of years of the pandemic and some other things, your hospital may go through any kind of layoffs. Hopefully not, but it's not as easy to lay off a biomed department if they're working on core devices like beds, nurse call, some of those other things that are just crucial. I mean, you got to have them. So that's what I would say.
Absolutely.
And y'all both touched on just so many things in that short window. So first off, Ryan, you mentioned all the different technologies within hospital beds. And if you consider from a hospital bed 10, 15 years ago compared to now, the renaissance that a hospital bed has had when it comes to the technologies, even the mattresses themselves, this can be a troubleshooting nightmare for a technician that has never messed with a bed. And to be honest, all of my Tech 1s have worked on a hospital bed. It has made them better technicians because you have hydraulics, you have sensors, you have, the membrane controls, you have scales. There is actually like full boards, compressors, systems inside these certain OEMs mattresses that connect and integrate communication-wise with the hospital beds as well. And being able to troubleshoot and follow and guide and utilize all the different components of a hospital bed for a patient, like, just having the ability to be able to press the button and call the nurse, or being able to raise the volume, lower the volume for their TV. These might seem like insignificant things, but it's something that, like Webb alluded to, patient satisfaction and them being comfortable while they're trying to recover from a surgery or perhaps an illness. Like, the idea is not to impact negatively a patient's experience. We want them to be as comfortable as possible.
Yeah.
And also the readiness aspect, what a lot of people don't speak of as well, when you're talking about Joint Commission, DMV, and all the regulatory compliance aspects of it as well. You have a certain amount of patients that is an ebb and flow within a hospital.
Mm-hmm.
And when you don't have a basic item such as a hospital bed, which all patients are going to experience at some point in time during their stay, even stretchers, if you don't have the amount you need to, then they might have to turn away patients or have to put them in a precarious situation that they shouldn't have to be in the first place.
I think that part of the reason that beds don't get the respect that they deserve is because of their redundancy, right? This isn't like your mammography machine where if it goes down, the hospital is usually canceling cases and losing money by the minute. You've got a lot of hospital beds. Of course, if you get them racked up in the hallway, you might invite scrutiny from leadership or from regulatory agencies. But it's not, we don't typically associate beds going down with like a DEFCON 4 scenario, right?
I've walked in the hospitals to where they literally have 30 to 40 down, and the hospital can only be at like half capacity because they've just piled up to that extent.
That's true, Chase. And talk about good and bad things about doing bed maintenance. Sometimes we treat beds like the IV pumps and other things. It's like, as a biomed in our world, we're hit with many different things that are breaking, and we have to choose things to put to the side. Well, a lot of times that can be the beds if you're busy in a busy season, but very quickly, if the census goes up or if you've got some weird kind of patient surge happening, which we've kind of been going through a little bit here within these last couple of weeks at TMC where I work. And all of a sudden it's like, hey, where's our beds? So I have to deploy most of our resources. Hey guys, stop what you're doing. Let's all get on beds for a while. And then we can quickly shift it to where it's like, okay, the beds, we fixed what we could. The rest have parts on order. So we're back in business. And that's one benefit to having a bed maintenance program in-house. You can just, in situations like that, you can kind of shift priorities and get things done quickly.
All right, Ryan threw down the gauntlet. He said in-house is better. Let's get him, Webb. No.
Well, I'll be honest with you. I completely agree with Ryan on that. I mean, I think that if you've got a robust in-house program, that's your best friend. And I think that a lot of like small to medium sized facilities, cross-training your techs is viable. If you're working for a really large health system, I think a lot of times we see like dedicated bed teams maybe more successful. The problem is not that an in-house program isn't great. The problem is like, how effective is your in-house program? To the point I was making earlier, Chase, like I've walked into the same scenario that you mentioned, right? But a lot of times with the bed program, it's just a matter of, hey, this process can be drastically improved, but there's other fires, there's other things that this department is dealing with. So it kind of gets put on the back burner.
Yeah, it gets added to the bottom of the list, whereas you have a system like what Ryan has in place to where it's effective, it's efficient, things are moving along. You know, you don't have an encapsulated pile of beds when you need them. When you're trying to debate about this, I can point towards one of the documentations and surveys that were done, the Amy Gray Areas report. One of those devices, depending on what system you're in, some people see it as a Biomeds job, some people see it as facilities, and a mixture of both. It just depends. When you consider the cost of having an inefficient program, no matter how you go about it, whether you're outsourcing it, you have an OEM come in, or you're kind of haphazardly maybe managing a team, but not really making it a priority, the cost can be scrupulous. Like I've seen some of these OEM bids to manage hospital beds, and it's millions of dollars.
Yeah.
When you honestly can do it for at least half that cost. The other aspect of that too is a lot of these systems I walk into, the hospital bed is one of the last things to get updated. I still see systems out there that are using beds 20, 30 years ago that one side rail completely doesn't work or the scale doesn't work. And they're using them like stretchers when they're actually hospital beds. Like I've seen some crazy things. I'm sure you guys have too. But when you're considering area responsibility and cost, it's something that Biomeds actually need to consider as a medical device. And it's so divided, which is part of the reason we're having this discussion today.
Well, I would definitely agree that the OEM experience can be stifling at times, and it can be very expensive. The OEMs typically deal with module level repair. So if you've got like a button that's wonky on a footboard or a side rail, in order to save time training their technicians and in order to save you time with them on site, a lot of times they're just going to replace the entire module, right, to the tune of a couple $1,000s and then charge the hospital. And those costs rack up. The point that I was making earlier is that, hey, an in-house program can be your best friend, but how effective is that program? Time is our ultimate inventory. And we've got to ask ourselves, like, is this the best use of bandwidth for our HTM department with everything else that they've got going on? What we find a lot of times, I'll talk to folks and they'll say, well, I've got an in-house program. When you peel back the curtain, they're leaning on OEM support 40, 50% on the time. Their technicians are going out. They're spending an hour or two doing a first call. Maybe they're getting on the phone with the OEM. I remember years ago, I was at a different company, but we had a technician who was going out doing beds, and this technician was phenomenal working on things like anesthesia machines, but beds weren't really their forte, and they were troubleshooting a lot. Well, I noticed that over, like 20 similar repairs, it was like the same $3,500 part, like for 18 of these repairs. And we got in there and, provided him one of our other bed techs. It was like, no, we don't. What the OEM is doing is, spending 15 minutes with you on the phone and being like, hey, replace the whole module. So we can really get ourselves into a bad situation where we're spending more money than we need to, or moreover, that we kind of go down this wormhole of trial and error parts ordering, where you've got a technician doing first call. Maybe they order the part. It takes a couple days to come in. Turns out maybe it's the wrong part. Maybe they order another part, maybe third time's the charm, and we call the OEM on site. And at the end of the year, we have an in-house program. We're paying our technicians salary. And if you've got 400 beds, the PMs alone, you're probably spending a couple hundred labor hours doing that. You add on repairs, probably spending close to 1,000 labor hours.
People don't realize like beds can be hard to find.
Yes, they can.
They disappear, which you wouldn't think as big as they are, but they can disappear.
Yep.
I've found beds in the basement laundry room of a hospital for no reason. They've never been there before, but it was there that time when we were looking to PM them.
That's a problem for me too. They get moved around. EVS, whether they're broken or working. But I'll add on to what Webb is talking about. So, this whole thing in-house versus a vendor, I feel like there's a right answer for every program out there. I don't want to, of course, I think a healthy in-house bed maintenance program is the best, but that's not going to work for every facility. It's dependent upon many factors, and you guys probably know about what those are. But I don't want to act like it's all roses over on the in-house side. There are struggles. Beds can be demanding from a labor perspective, like Webb said. Every day you're going to get beds coming in, that need to be addressed. So I feel like if you are going to have an in-house program, it's all about the culture that you kind of develop and sustain about beds, right? Like that's one of the hardest parts, and people combat that differently. Sometimes a program, they'll have just like one guy. That's the guy. That's the bed guy. And I've never really wanted to subscribe to that. Part of what makes this job fun for me is like everyone else, I'm sure, in the field is that we get to work on many different things. It's always something different every day. So if you I can't, as a manager, tell an employee, a fellow biomed, hey, this is all you get to work on. Sorry, buddy. Nurse calling beds for you. That's it. I couldn't do that. I wouldn't want that for myself. And so I try to kind of embrace an all hands on deck approach to beds and nurse call as well. We're not talking about nurse call, but, and that works for me. It's not going to work everywhere, and I get that. You try to tell some biomeds, hey, you're working on beds and nurse call and all this. All right, I'm going to go down the road and go work over there. So I get it. It's not always easy to do that, but that's kind of what I try to do here.
What you're describing sounds like the gold example. That's ideally, we wish it was like that.
It's just not always, though.
For the point he made, one thing I see a lot is departments they'll either have like a really old biomed who's just content working on the beds, or they put their greenhorns on it. And I definitely think the latter is kind of the wrong approach. There was a study that came out recently that says there's something to the tune of like 7,000 biomeds that we are needing to fill in the United States, about 7,000 biomed roles annually. And our BMET programs are graduating on average about 400 biomeds. So obviously a huge conversation in our industry is, this gap of the older crowd retiring. We need more young people involved. I think when I see, hospitals that just dedicate like a BMET 1 to this, what happens a lot of times is that those technicians are not fulfilled. They want to further their career. They want to work on sexy equipment. They want to work on imaging equipment. I don't think you'll find a lot of biomeds who saw a, patient bed when they were 18 and was like, that's what I want to do. So if that's all they're doing, it's not going to be long before another health system comes up and offers them a shot, working on imaging or anesthesia or something they want, and then they're gone. And hiring biomeds is really, really tough.
So to caveat on that, since you primarily do beds and stretchers, how has that worked for you with hiring and having people just open and willing to just work on beds and stretchers?
With our program, we hire biomeds. We also hire sometimes like motorcycle mechanics, right? So what we'll do is we'll put them through a month of training. We've got a training facility here in DFW. And when they're cut loose, they're going to shadow one of our senior technicians for 2 months. By the time all that's said and done, you've got a technician who has been through 3 months of training that's really passionate about beds. And it's part of our culture at Emeritus. We're excited about patient beds and stretchers where other people may not be. That's what we're dedicated to. And I will say that, one of the cool things about Emeritus is that our program runs like an in-house program. We're an outsourced expertise with a truly in-house feel. We aim to put a technician or a team of technicians on site full-time, 5 days a week. So they're reporting directly to biomed in facilities. Moreover, they're building rapport, with your nursing, your EVS teams, your transporters. We stock OEM parts on site. And in addition to that, we bill our customers at a firm fixed fee. So rather than, cutting 4, 5, 600, 1,000 POs throughout the calendar year, you get one invoice a month, covers all your repairs and PMs.
So a full service aspect.
Yes.
Okay.
But when I say it's like an in-house program, what I really mean is this, like you're getting an unbiased approach, right? Whereas you work with an OEM, and you're paying for these module level repairs, you may have an OEM that's really good at working on their beds. But if you've got a mixed bag of inventory, they may not be experts on all your inventory, and they're constantly trying to upsell you. Furthermore, we are interested, like an in-house program would be, in keeping the cost down and saving the landfill, right? By doing component level repair versus module level repair. We're also interested in life cycle extension, whereas an OEM is going to recommend, they're going to push you to replace these beds like every 5 years. There was a really interesting article that came out last year by Insung Wang that said that an analysis of extensive data with about 340,000 pieces of equipment maintained for over 30 years was recently completed. And that study found that medical equipment can remain safe and reliable for more than twice the estimated useful life suggested by the American Hospital Association. So when you consider that we're going to be developing relationships, offering things like transporter training or doing mattress defect identification, offering in-service training like your, biomed department would be doing, you can see where this truly feels like an in-house program. And I tell people, like, our, Emeritus Bed Maintenance 2.0, it's not a perfect fit for everyone, but it's really transformative for some. So it's like, look, if you're not there yet, let's put you on the road to get there so that you can have a really robust in-house program.
So I can appreciate several things that each of you guys alluded to. So Ryan, the fact that you have, you're cognizant of, you want everybody to be involved in every aspect of the medical devices within your facility. I've heard of techs just being stuck on a bench and all they work on are IV pumps. There are techs out there, all they do are beds. To me, it doesn't matter the exact modality that they're working on, but you got to have a wide open approach to what you're actually expecting your technicians to do. I have walked into situations to where, like, you guys alluded to, a BMET 1 gets put on to work on beds. I've seen to where, like, a facilities guy who has only done HVAC for his entire life gets told to, hey, we need you to work on this bed. And he spends all this time just trying to figure out how stuff works. And it's not very effective. Usually, most of the time, which I'm sure Webb can allude to this as well, is facilities gets thrown the maintenance at beds and they do their best to try to manage it. And then it ends up getting thrown to a ISO third party or to the OEM, and they don't know if they're actually doing a good job to maintain it.
Right.
One of the contracts that I've came into, we found some patient safety level modifications to beds that shouldn't exist at all, simply because they didn't know what they were doing. And the training aspect is a huge part of this. I also love that you touched on the fact that medical devices last way longer than OEMs want us to believe. The fact of the matter is they are obsolescing them simply so that they can upsell you for the next thing. So hopefully, larger the big players, you're not going to, no reason to name them. There's only a few manufacturers that make beds. Yeah. But if they stop making a particular board that supports this, hopefully you have a company that has the ability to have access to that board or troubleshoot on the component level to where it's cost effective. There's hospital beds now that can cost $40,000 to $50,000 a piece. And that's not including the mattress, which can cost another $8,000 to $12,000 to go on that bed. And then you got to consider the maintenance of it and everything involved down the line for the next however long you decide to keep that bed. But from an aspect of life cycle management, for instance, there's a particular bed that you can still buy parts for, but it's not the latest and greatest. However, if you have the footboard go down, like the board inside it just goes kaput, which, with the age of it makes sense. To replace that footboard costs more than you can buy that bed refurbished as a whole. And the newer models of beds, footboards can cost $15,000. The thing is, this is your life of the bed. All the software revisions take the weight of the patient to troubleshoot the bed, gives you error codes. Like there's so much involved nowadays that if you don't have a tight grasp of what you're messing with, then outsourcing it to the guy that's been working on HVAC or a brand new biomed that is just graduating, it's not going to be effective.
beds exist in a no man's land. And it's weird that like 50% of the, hospitals I talk to, they are managed by facilities, and facilities is in the deep end. They're in over their head with this stuff. And a lot of times they outsource it. Chase, to your point, they've got no way of telling, if they're in a good program or a bad program. Biomed departments, I think have sometimes run into issues with explaining or justifying, their budgets with the C-suites, right? And if we can extend the life cycle of the beds, there's a big argument to be made to show the actual value of the biomed department. It increase our budget.
So you're saying taking on work that we necessarily don't want to do might actually help us in the long run.
Absolutely. I mean,
Go
think
figure.
about how the OEMs, they are constantly trying to upsell you, whereas we know that, your beds, like they're would want to maybe say new beds every 4 to 5 years. If you're working at a hospital system and you've got 3,500 beds that you buy from the OEM, you're not buying them all in 1 year, granted, but let's say those beds cost $14.5K. Okay. You're going to be spending what, like $51 million, right? If you can double that life cycle, even to like 7, 8 years, you can make a case to your C-suites that you're saving them $7 million a year.
Yeah, absolutely. And it also allows them to effectively budget and plan for when the time comes to need to upgrade those.
When I think about beds, there's whether or not your biomed department is turning the wrenches themselves, it has to be managed by us. The vendor who's working on the beds, if you're going to choose to outsource, whether that's OEM or a good service company like the one Webb works for, who's keeping track of those repairs? Who is managing that vendor? It has to be Biomed. I don't think it would be successful unless we are the ones doing that. But another thing that I'll add is think about all of the other things we bring to the table that aren't just turning a wrench. We help with projects, integration. You talk about fall risk. Nobody wants patients to fall in their hospital. These beds interface to the nurse call system. Who's going to bridge that technical gap that the nurses have? We know that those gaps exist because we help them with other technologies. They need our help. Who's going to have those conversations with them if we're not doing that? Is Plan Ops going to go up there and make sure the beds interface to the nurse call and all these other these things that are going on? Maybe if you have a good Plan Ops department, but it seems a little bit more up our alley. Here at Texoma, I've helped on many different projects with beds that nursing has, whether it's where do we store our beds, how are our mattresses being inspected, what should we do there, there's a lot of stuff that we do behind the scenes that aren't just related to maintenance as a biomed department, and we need to apply those skills to the beds also.
Yeah. I mean, you bring up a really good point, Ryan. There's a lot more that the HTM department's doing, and that's probably why during the pandemic, they were, one of the first departments to be named essential workers. At Emeritus, like I mentioned, we do in-service training. And one thing I get a lot of pushback on, like we'll do transporter training, because the idea being like, look, especially if you ask a facilities manager, I'm sure you've seen this, Ryan, where you've got nurses ripping cords out of wall. You might have a 100-pound nurse, pushing a 600-pound bed around the hospital. It's like, what can go wrong? Well, ask your facilities manager if they've ever had to replace an elevator. But when we talk about this stuff, a lot of people will sound like it's a lost cause. Like you can't, hey, our transport team has really high turnover. So like we've tried that before, but it's not going to work. And I think it's just a matter of consistency. Some of those rough edges being refined that you're talking about on top of doing the maintenance, it can definitely be done. It just takes dedication and it takes a strategic approach.
It's the willingness to do the work. If you consider how many different hats that a biomed has accumulated over the years, more and more is asked of us. However, the more that's asked of us, there are certain key things that some people are more inclined to be excited about. They're like, oh, we're biomed's branching into IT. Well, IT's, for the most part, been integrated in a lot of what we do because we have to work alongside them with integrating, make sure the device talks, stuff like that. Like IT doesn't know how to set that up on a device. Well, hospital beds do that too. Some of the newer ones, like you have to integrate them with IT. On top of that, what's another thing that biomeds inherently, it's not necessarily part of the job task, but you end up doing it a lot. It's in-service training. So when we talk about engaging and building relationships and talking with our clinicians, doctors, and all the people that we see on a day-to-day basis in the hospitals, it's no sweat for a technician to walk up and say, hey, the reason your your monitor is giving you this weird reading is you don't actually have it set to give you your diastolic systolic. You have it set to give you MAP. Well, some nurses don't read MAP. They read the 120/80. Just doing simple trainings on all of our different medical devices, it's the same aspect with hospital beds. This is a simple way that is patient facing and clinician facing that is an easy way for a biomed to show their worth. Yeah. We always complain about that we're always in the dungeon. We're always in the basement. Like, nobody sees what a biomed does. Every time I've gone in to fix or assess or troubleshoot a problem with the bed, usually a patient and their family's in the room. I've had patients in the bed while I'm trying to go through the error codes. I've had so many amazing conversations with patients and, speaking to their families, and I leave out of there. And I've actually had some of them actually comment, I appreciate that you got somebody in here so quickly to make sure that my dad is comfortable. We've had beds that needed to get moved out of the room because it was that egregiously broken. Got in there, we assessed it. Hey, we need to pull this, get them in there, get EVS, move the bed, that kind of thing. Like, this is an easy opportunity for us to say, hey, I'm a biomed. Oh, what's that? Well, let me tell you. Wow, I should get my grandson into that. My daughter's son is about to graduate and they're looking for what to do. I've had those conversations as well, just by simply talking to family while I'm working on a hospital bed.
They say that, biomeds are the silent heroes of healthcare, but they don't have to be. And to your point, and what we were saying earlier about the inpatient experience and patient satisfaction, look, it's not just the patient that understands beds and comfortable sleep. Their families are at the hospital too. So for each inpatient experience, you might have 5, 10, 15, 20 people leaving, your hospital with their mind made up about how that hospital conducts itself, how that staff performs.
Actually, the local hospital 5 minutes from my house where my wife gave birth to my son, I work on those beds personally.
Awesome.
Like, it's something I would have never considered, a couple of years ago when I wasn't expecting a kid. And then fast forward to now, and literally the PM sticker and everything that went along with that bed, I personally worked on. Like, it's that little satisfaction in knowing that, like, you played a part in just a different
Chase, don't you feel sometimes doing this job, like, even if you don't want to do something, sometimes we're just called to do it. Like, beds, I feel like beds are that for me. How can I hear about issues with beds going on and nurses need help? The CNOs having problems. They want to figure out, why can't the beds integrate to the nurse call system? This was a problem they were talking about for a long time. And when I became in-house, I'm like, I can't help myself but to want to help you and try to figure this out, because I know that we can. And so that's how I feel about the beds. It's like, they're not the coolest technology. Maybe they're not the things that we all got into this line of work for, but it's our duty to take care of those, man. We have to.
It's not the sexiest thing, but it's the necessary thing. And every facility has them. We touched on the beds, and, Brian, do y'all work on the stretchers as well?
We do. Yeah.
We've talked about all the wonderful and good feeling fluffy things about beds. So now I want to talk about, like, what do you hate about hospital beds and stretchers? Because there's some things I just absolutely just drive me nuts when I see them. So I if you have a personal story or just something that you just see so often, you're like, why?
Yeah, it's funny for me, the stretchers, like, at first I tried not to take those on. I'm like, we're doing beds only. Stretchers got to stay over there, plan ops. And I held that position for a while until, at one point, I think I was talking to my corporate director, and he's like, it makes sense for y'all to do the stretchers. You're already doing the beds. And I agreed. So that's where I kind of drew the line, though. Like, we're not getting into recliners and those little tables that go over the bed or any kind of furniture like that. But the stretchers, the biggest problem for us has been kind of what you're talking about earlier with the end of service declarations that are happening. There's parts we can't get. And this has actually been a big issue because when the stretcher breaks, it essentially becomes useless and we have to retire it. And right now, we need more stretchers. So we're having to kind of just see what we can do to get every stretcher we have up and running and purchase more because there's some out there that, sure, we can fix them if we could get the parts, but they're no longer being sold. So that's the biggest thing for us out here.
We work on the stretchers as well. And look, parts are on back order sometimes. What we'll do is stock OEM parts on site. And granted, we've got our hero kit's already out in the field. So typically, before we need to order new parts, if we use a part, we can pull from our own internal stock. But hey, that happens sometimes.
I found out from one of the manufacturers that when a stretcher is being ordered, so it's kind of like, how you got your cars, you got like the limited, the SE, the sport, and then you got the luxury. So most of the time, at least with this manufacturer, I can't speak for all of them, but you got your baseline stretcher, right? And then all the stuff they want added onto it, the different capabilities, like let's say if they want to add scale or they want to have this little doodad on their IV pole, all that kind of stuff, it's done during the ordering process. And then let's say you are the technician and you're calling to get a part number, and I've asked the manufacturer, I'm like, here's the serial number, but they cannot tell me all the different features that the stretcher comes with. Just because you have that model, it doesn't necessarily mean that all of them are going to pull up with the exact same thing, because they can have all these different bells and whistles that the tech support of that manufacturer can't see. And they don't track that in their system. So you have to, hopefully your purchasing department can tell you exactly all the different things that make that particular stretcher different.
That might, you just reminded me of something, Chase. Something like this happened out here with one of our stretchers. There's a part that fails where, you can push the handle and let the head come down. And we order this part to replace that. And every time we order it, it's the wrong length and and we've told them, and they're like, no, that's the right part. And we're like, well, no, it's not. So then they have to send somebody out, and we show them, like, yeah, you're right. I feel like we're still battling that today, and even after they've identified that there's an issue. So yeah, I think that's probably about related to what you're saying.
And then I'm sure y'all can also allude to this too, like, and this is for medical devices in general. The OEM will update the part numbers and not make that known, or they'll update them and not let their own internal departments know. So I've seen it to where, like, you'll go on the manuals, like there's a couple of the OEMs that actually make all the manuals available for all their different models, but they don't update their catalog part numbers. So, shocker. If it makes you feel any better, Biomeds out there that are not working on beds, if you do get into it, you're going to have the same issues, troubles, and heartaches that you do with other devices with beds as well. So at least there's normalcy with that.
Well, I think that's why, to what we were saying earlier, there's a big benefit in improving the life cycle of these beds and learning them frontwards and backwards, right? Because I think that's partly how the manufacturers keep us on our toes, is by those regular changes.
I mean, kind of what we talked about earlier with the advanced technology. Like, if you think beds, these aren't the beds of 20 years ago, right? Like, they're not as easy to fix as you think, especially these critical care beds. Like, they can really throw even the best technician.
Yeah, the ICU beds are gnarly.
Yeah,
dude.
I would just say, like, you don't get rid of that stigma that nobody wants to work on those, or that, whatever it is in your head, beds suck. I don't know. Just quit with that and realize how important they are to your hospital, and how much you will be valued as a department when you take that on, because I can tell you they do appreciate it, like you said, Chase. So that's what I would say.
Everyone's got parts of their job that are not their favorites, right? Like, at the end of the day, we still got to do work orders. I think that, if I was going to make that case from Emeritus, I'd say, let us show you firsthand. Have your technicians come by our training, or moreover, let us help you build a robust in-house program. Let us get your technicians cross-trained.
Ideally, I think we're all in agreement that this is something that a biomed should take on. And it's a medical device, even stretchers. Like, there's a lot of benefit to learning and troubleshooting these things. My technicians, even though they egregiously like, oh, really, we got to do beds. Afterwards, when they fix one, I've had a couple like, wow, I actually feel like reward after this, because it was so hard troubleshooting it, and now I know it.
It's not just a medical device. It's arguably one of the most important medical devices in your hospital, because again, it's going to affect the inpatient experience more than any other medical device.
Yep.
Biomeds wear multitudes of hats, and we're capable of so much, and we're capable of justifying what we're able to do through other means outside of just doing your standard patient monitors, IV pumps, x-rays, anesthesia, etc. There's so much more in the world of outside of the generalized infrastructure of biomed. So I appreciate you guys willing to come on and have this discussion.
Ryan, I will say I appreciate you so much because I know, we talked about the Bed Maintenance 2.0 program earlier in the year. And just for anyone who's listening that doesn't know, is Ryan has given a presentation before MD Expo that I saw about how to build a really quality in-house bed program. And Ryan, I'm sure you can probably provide a link to that if you want. But even with that said, and understanding that's kind of one of your core philosophies, I remember you called me earlier in the year. It was like, hey, I'm still a manager. I want to do my due diligence. Just check out what you guys are doing at Emeritus. And so I really appreciate that.
Ryan, if you have that link, share it to me. I'd love to post that in the description as well so people can look on that.
Absolutely.
Web.
And I'll tell you what, I can provide you some information about Emeritus Clinical Solutions as well that you could provide on the pod.
So for anyone, if anything came from this episode, I hope you embrace the idea of beds, of stretchers, how much this can actually benefit your medical facility and how much it can benefit your technicians in your own, even if you're ISO third party in-house, it doesn't matter. Everybody can benefit from being able to service, learn, and take care of beds and stretchers. It's a critical part of our medical infrastructure and taking care of our patients and their comfortability during their stays. So with that, I appreciate you guys being on the show. Anybody watching, listening, Spotify, Apple, YouTube, like, subscribe, share, follow, let people know about Bearded Biomed. Help this show grow. The bigger we get, the more content I can provide. Do bigger and bearded things. May the beard be with you, and we'll catch you on the next episode. Take care.
Chase, thanks for having me.
Bearded Biomed.